Hello, my name is Dr. Stephen Martz. I'm one of the consultant paediatric nephrologists at Great Ormond Street Hospital in London. It gives me great pleasure to introduce Emeritus Professor Michael Dillon, who's known to one and all as Mike. He first came to Great Ormond Street Hospital in 1969, was appointed to the staff in 1975 and retired in 2002, but remained very active within the field of paediatric nephrology, giving lectures around the world. So Mike, tell us a little bit about what the conditions were like at the start of your career.
Well, when I was a medical student in the 1950s, paediatric nephrology really didn't exist as a specialty, and most renal problems in childhood were dealt with by general paediatricians with the help of adult nephrologists from time to time. And sometimes adult nephrologists saw the patients with the help of paediatricians. Subsequently, in the 1960s, when I was a junior doctor, paediatric nephrology was on the map because of Gavin O'Neill setting up the unit in Glasgow. And there were the beginnings of units in Birmingham with Dick White, Manchester with Ian Houston, Guy's with Stuart Cameron, who preceded Cyril Chandler with paediatric nephrology there, and Great Ormond Street with my colleague Martin Barrett. But still, it was embryonic, and we were very limited in terms of what we could do, basically because there weren't the sort of modern advances that have revolutionized our investigation and treatment of children. But in the early days at Great Ormond Street, there were problems which were linked to the fact that we were not involved with hemodialysis nor transplantation, and we were very heavily reliant on the goodwill of colleagues at Guy's Hospital and at the Royal Free Hospital, both for hemodialysis, with Guy's dealing with the younger or smaller children and the Royal Free with the older teenage youngsters, and the transplant surgeons were based at both those hospitals, Ozzy Fernando at the Royal Free and Mick Buick at Guy's. So the situation was rather different to what everybody experiences now. And I think that was essentially because we didn't here at Great Ormond Street have those facilities that we wanted, although other units did, bit by bit. And we were limited by the inadequacy in terms of drug treatment for many of the illnesses with immunological bases that we now take for granted. And we were limited by the investigative tools that we had available. There were no ultrasounds or isotope scans or MRIs and CTs and angiography of the sort that we take for granted. So we led a rather primitive life, but managed to achieve, I think, sort of satisfactory results with what we had available.
During your career as a consultant, honorary consultant for 27 years, what would you say was the biggest discovery or treatment during that time?
Well, I think in the early days, from our perspective, it was the ability to hemodialyse children at ever younger ages and transplant them when in end-stage failure, whereas previously children with that diagnosis were quite often given a death sentence by the dint of no means by which they could be managed. So I think that revolutionised how children were managed with nephrological disease. But the other important developments were those associated with the increasing number of immunosuppressive agents, which were important for transplantation purposes, but also for immune-based renal disease. We were essentially treating children with only steroid and subsequently perhaps azathioprine and cyclophosphamide, and that was it. So I feel that the addition of those drugs made an enormous difference to our achievements, as indeed with other conditions like hypertension, where new drugs were available, where old-fashioned ones were inadequate and we were in difficulties. And I suppose more recently, the development of molecular genetics, which suddenly created a scene where we were able to diagnose very specifically genetically determined disorders, whereas previously we had to rely on our clinical acumen and the historical evidence that was available, and sometimes had to use hunches rather than certainties about the nature of conditions.
Most of modern day paediatric nephrologists and the trainees talk about the negativities related to corticosteroids and prednisolone, but of course it saved many children's lives over the years, didn't it?
Yes, indeed. And I can remember that when I was a student and a junior doctor, an example of steroid having a major impact was that children with, for example, polyarteritis nodosa had 100% mortality until steroids came on the scene, and then the mortality was reduced to about 50%, and then, as we know, the situation is very different now. And nephrotic syndrome, of course, was an impossibility in terms of treatment. And I can even recall now finding resistant nephrotics requiring Southey's tubes inserted into the legs, with the children sort of sitting on benches with their legs in buckets so that the edema could be drained away, because we didn't have adequate and strong enough diuretics to manage such things.
Can you tell us a little bit about how things change with respect to imaging? So, first of all, not being able to do ultrasounds and...
Well, we used to have to use intravenous urography as one of our mainstays, and of course, in terms of bladders and reflux, contrast micturating cystograms. But we did not have at our fingertips ultrasound, which revolutionised many of our investigative procedures and our renal biopsy technology. And we didn't have isotope scanning, which also came in some time later. So we were quite often rather limited in what we could deduce from the imaging technology that we had. And on top of that, of course, there was radiation exposure that in repeated episodes could accumulate to potentially dangerous levels.
How did you first do renal biopsies when they first started, and how was the interpretation of the renal biopsies done with pathologists?
When I first started, renal biopsies were undertaken using the modified Wim-Silverman needles. We would mark out the site of the lower pole of the offending kidney with marks on the child's back based on either an IVU preceding the procedure or by calculated guesswork, if you might put it that way. and we aimed at what we hoped was the appropriate spot, and we were sometimes somewhat out of sync with the reality. We then used scanning technology radiologically at the time of the investigation, which made a considerable difference, but again, radiation was the factor against it. And finally, of course, ultrasound made a lot of difference. We did have at Great Ormond Street, fortunately, some dedicated pathologists who were particularly interested in renal disease, and so we had a high-class service that was available to us. But we didn't have electron microscopy, and much of it was initially just light microscopy, with later immunofluorescence coming in as an additional benefit.
So tell us, Mike, who was your inspiration at the start of your own career in paediatric nephrology?
Well, I have a number of people that inspired me. One person who inspired me in terms of paediatrics was Philip Evans, the doyen of paediatrics in Great Britain at that time, who was the senior paediatrician at Guy's and at Great Ormond Street. I was so impressed by him, I tried to model my practice as a paediatrician on the skills that he taught me. The second person that made a major impact on me was Professor Stanley Peart, the Professor of Medicine at St Mary's, my medical school, with whom I linked closely during my research period. He was a brilliant academic and a brilliant clinician, and was someone who led me into the renin-angiotensin system, where I had vowed never to go initially, but for whom I was very grateful when things turned out as they did. I was then impressed and stimulated by Stuart Cameron, who I felt was rather like me, a butterfly in terms of research interests, flitting from flower to flower. Great fun, but no Nobel Prizes as a result. And then John Suttill, in whose department I worked in the embryonic renal unit at Great Ormond Street. Barbara Clayton, the chemical pathologist, who was an enormous support during my research years. And of course my colleague Martin Barrett, with whom I worked for so many years, who I linked closely with at the beginning of my nephrological training and experience, and for whom I had a lot of respect, and who had an influence on me in those early times, and of course subsequently was a very loyal and good colleague.
What advice do you have for the next generation of paediatric nephrologists coming through?
Well, I'd say it's a good specialty to be involved in. It's got many rewards. Now there are so many advances in management of children that with renal disease that I think there is the possibility of making an absolutely considerable impact on childhood disease, whereas earlier on there were limitations. And I would say go for it. The specialty wants aspirational, young, enthusiastic paediatricians specialising in nephrology, and I would very much encourage those that comply with that description should seriously think about paediatric nephrology as a career. I don't regret my life in paediatric nephrology, and I would think that I'm not an exception. Others would perhaps feel the same if they went into the area.
When you think back through your amazing career, can you tell us maybe about one patient that sticks in your mind or lessons that you learned from your experience of managing some of your patients?
Well, I think it's difficult to pick out one. There are so many that would come to mind. But one of the things that always has struck me is how children with the most disastrous conditions bravely face a challenge and in spite of everything remain cheerful and well-rounded individuals that one would have thought would have been completely flattened by what's happened to them. And there were many patients in that sort of category that I dealt with. But in terms of the specifics, I would have, at this moment, with that googly you've just bowled me, difficulty in singling one out.
We look forward to welcoming you to my hometown in Glasgow for the 50th anniversary meeting of the European Society for Paediatric Nephrology. Is there anything lastly you would like to tell everybody about what you've learned in the last years, and where should we go in the next 50 years of paediatric nephrology?
Well, there are all sorts of advances that are on the edge of coming to fruition. The use of stem cells in renal disease is an exciting arena, and I feel fairly confident that that's actually going to evolve into a beneficial service that we'll have available to us. And I think there are going to be more specific immunosuppressive agents, bullets, not bombs, that are going to emerge dealing with particular facets of the immune process that will target critical areas for specific diseases. And I suspect that we're going to learn much more about many of the diseases that we have dealt with that are not obviously genetically determined, but I'm sure that the processes that go awry in relation to nephrological disease to do perhaps with immunological processes have all got genetic components, and we'll do much better if we know what they are and how to handle them.
Thank you very much indeed, Mike, for coming and speaking to us, and we look forward to seeing you at ESPN.
It's been a pleasure.